Let's be real for a second. The transition from the womb to the outside world is literally one of the most dramatic physical transformations a human being will ever go through. Welcome to the fourth trimester. In this explainer, we're going to break down the exact clinical assessments, those profound psychological shifts, and the absolute must-know safety protocols that get a newborn safely from the delivery room to their own crib at home.
Here is our roadmap for today. We're covering the delivery room baseline, testing the neurological wiring, the psychological shift, fueling the fire, safe and sound at home, and finally, spotting clinical red flags. Let's dive in.
Starting right at the beginning with Section 1, the delivery room baseline. You're probably already familiar with the APGAR score, but think of it as your ultimate rapid-fire checklist. It's done at exactly 1 and 5 minutes of life to see how well that baby is handling the outside world. We're scoring 5 critical areas: heart rate, respiratory rate, muscle tone, reflex irritability, and color. Each gets a score from 0 to 2. If a baby scores a 7 to 10, awesome, they're having almost no difficulty transitioning. But if that score tanks into the 0 to 3 range, that is severe distress, and it means you're initiating resuscitation immediately. It's highly efficient for assessing and intervening right on the spot.
Now let's talk temperature. A newborn's temp absolutely has to stay above a strict minimum baseline of 36.5 degrees Celsius, which is about 97.7 degrees Fahrenheit. Why this specific number? Well, newborns have this massive surface-to-weight ratio, and they can't just shiver to warm up like we do. Instead, they metabolize what's called brown fat. If they get chilled, a state we call cold stress, their oxygen demands skyrocket, and they rapidly burn through those brown fat reserves. That chain reaction quickly leads to hypoxia and hypoglycemia. That's exactly why drawing the baby immediately and getting them into skin-to-skin contact with a parent is the absolute gold standard for thermoregulation.
Moving right along to Section 2, testing the neurological wiring. So, when you're doing a standard neurologic exam in that first 24 hours, you're expecting a healthy newborn to show very specific, symmetrical physical reflexes. You're looking for the rooting and sucking reflexes, obviously essential for finding a nipple and getting nutrition. You've got the palmar grasp, where those tiny fingers curl tightly around yours, confirming basic neurologic tone. We also check the Babinski reflex. When you stroke the outer edge of the sole, their toes should fan upward and out. Totally normal in newborns. But if that response is absent, it immediately points to a potential neurologic deficit. Here is a huge assessment priority for you, the Moro reflex. You trigger this by gently pulling up on the newborn's arms while they're laying flat on their back, and then releasing them. They should symmetrically extend and abduct their arms, with their fingers forming a little C shape. Now remember this, an absent or asymmetric Moro reflex is a massive red flag. If only one arm extends, it's a primary indicator of birth trauma. We're talking things like a fractured clavicle or a brachial plexus nerve injury that happened during delivery. All right, shifting gears a bit to Section 3, the psychological shift. It's not just the baby adapting, right? Taking care of a brand new human requires a profound personal transformation for the parents, too. Maternal role attainment generally happens in 3 deeply emotional phases. First up is the taking in phase, during the first 24 to 48 hours. The parent is often quite dependent here, really focusing on their own physical recovery and processing the birth. By day 2 or 3, they move into the taking hold phase, which lasts a few weeks. The focus shifts to baby care and building confidence. But heads up, physical discomfort and emotional lability, yep, the baby blues, are incredibly common right here. Finally, the letting go phase spans up to 4 months. This is where the newborn is fully integrated into the family and parents resume their individual and intimate roles. When we recognize these phases as a totally normal human experience, it lets us provide genuine empathy and the exact right support when they need it most. Up next, Section 4, fueling the fire. A healthy newborn is burning a ton of energy. They require roughly 110 to 135 kilocalories per kilogram per day just to fuel all that rapid brain and body development. Now, parents generally have 2 primary pathways. Breastfeeding provides unique IgA passive immunity through colostrum. It promotes rapid brain growth and offers the flexibility of feeding on demand, usually about 8 to 12 times a day. On the flip side, formula feeding is also a fantastic source of nutrition, though it requires iron-fortified preparation until the baby is 12 months old. But if bottle feeding, there's a strict safety protocol you have to teach. Hold the newborn semi-upright at a 45-degree angle. Never, ever prop the bottle. Propping introduces a very real, very dangerous risk of aspiration. Handled correctly, both methods deliver the crucial fuel that infant absolutely needs to thrive. Moving on to Section 5, safe and sound at home. Newborns are usually pretty good at clearing their own secretions, but when they do need mechanical help with the bulb syringe, here is a pro tip you have to hammer home on your safety checklist. Always suction the mouth before the nose. Why? Well, if you suction the nose first, that sudden stimulation might cause the baby to gasp, and they'll aspirate any mucus that's lingering right there in their mouth. So, sequence it like this. Compress the bulb, insert it into the side of the mouth to dodge that gag reflex, aspirate the mouth, and then tackle the nostrils.
When it comes to preventing sudden unexpected infant death, or SUD, the rules are non-negotiable. The baby has to sleep in a supine position, flat on their back on a firm mattress. Absolutely no bumper pads, no loose linens, no toys, and no pillows in that bassinet. Room sharing is highly recommended, but bed sharing is a hard no. And when it's time to head out and travel, that car seat must be rear-facing, ideally placed right in the middle of the back seat and installed at a strict 45-degree angle. That exact angle is what prevents the newborn's heavy head from slumping forward and cutting off their tiny airway.
Finally, let's wrap up with Section 6, Spotting Clinical Red Flags. Thinking back to what we said earlier about thermoregulation and brown fat, this number right here is an absolute clinical threshold. If a newborn's blood glucose drops below 40 to 45 milligrams per deciliter, you are looking at dangerous hypoglycemia. You've got to watch closely for the symptoms: jitteriness, tremors, lethargy, or a really weak, high-pitched cry. Since their constant maternal supply of glucose has been cut off, these at-risk babies need immediate feeding interventions or even intravenous glucose to prevent potential neurologic injury and seizures.
So, considering everything we've talked about regarding normal transitions and expected behaviors, what are the undeniable, absolutely do not wait signs that it's time to stop just observing and immediately seek professional medical help? These are your non-negotiable red flags. A temp over 38 degrees Celsius or dropping below 36.5 degrees Celsius is a major warning sign of a potential infection or cold stress. And look, while fussiness is a given, truly inconsolable crying, or on the flip side, extreme lethargy where you literally cannot wake the baby, are not normal. Keep an eye out for jaundice, which is that yellowing of the skin or the whites of the eyes. But most critically, any signs of respiratory distress are life-threatening emergencies. Labored breathing with flared nostrils, expiratory grunting, cyanosis, or stopping breathing for more than 15 seconds, those require swift, immediate action. The transition to extrauterine life really is a biological marvel. By mastering these clinical assessments, physiological milestones, and the deep emotional adaptation phases, we bridge that crucial gap between clinical medical knowledge and truly empowered caregiving. It's really about helping a newly formed family thrive during one of the most stressful, chaotic, and beautiful transitions in human existence. Given the sheer mountain of education required in those first 48 hours alone, how will you use this knowledge to better support and maybe even reinvent the miraculous journey of the fourth trimester?